Hi everyone! So together with my colleagues, Professor De Vijter and Professor Klaas, we will discuss two patient cases. Both cases are immunological challenged patients. The first patient is blood group incompatible with the donor and the second patient is highly immunized. So what are their options? Where do these patients run into and how can we help them? The first patient is a 46-year-old female with hypertensive nephropathy in her medical history. She's not on dialysis yet, but she has end-stage renal disease. Her husband wishes to donate his kidney. They have no kids. The donor has blood group A and the patient blood group O with an anti-A IgG titer of 1:128. So the blood group is incompatible. Is it still possible for the husband to donate? What are the options in this case? And what are the principles, the outcomes and the challenges? So we will ask Professor De Vijter.
Hello everyone. There are at least two good reasons to increase the number of live donor transplants. First, this discrepancy between the available organs for transplantation and the increasing number of patients on the waiting list. Secondly, the superior graft and patient survival rates obtained with these live donors will also reduce the need for repeat transplants. The evolution of living donation over the past decades actually is a story of crossing psychological and immunological barriers. A good genetic match for HLA antigens initially was a prerequisite for live donation, but with time, better unmatched relatives and unrelated donors are nowadays widely accepted as kidney donors. The Netherlands was one of the first countries to initiate a paired exchange program in case of ABO blood group incompatibility or a positive cross-match between the donor and his recipient. Despite crossing these psychological hurdles, the unmet need for kidney transplants forced further exploration of immunological barriers in case of ABO incompatibility or a positive cross-match between the donor and the recipient. So when do we currently consider an ABO incompatible procedure? Obviously in case no suitable ABO compatible donor is available and/or patient or donor persists in having principal or emotional objections against the option of paired exchange. ABO 0 recipients in paired exchange programs should anticipate on prolonged waiting times and relatively low success rates. In these patients, or the option of a preemptive procedure, we offer individual risk-benefit counseling for an ABO incompatible transplant procedure. So what is the actual challenge? The challenge is to prevent tissue damage due to hyperacute or acute antibody-mediated rejection. The diagnostic criteria for this entity include tissue morphology, immunopathology, and/or the presence of donor-specific antibodies in the circulation. So successful ABO incompatible kidney transplantation requires the reduction of these anti-A or B titers against these ABO antigens at the time of implantation and probably during the first critical 2 weeks post-transplantation. This phenomenon, without graft rejection, despite re-emergence of the specific antibodies, has been named accommodation. The mechanisms involved and its very existence, however, remain speculative. Is to prevent tissue damage due to hyperacute or acute antibody-mediated rejection. The diagnostic criteria for this entity include tissue morphology, immunopathology, and/or the presence of donor-specific antibodies in the circulation. So successful ABO incompatible kidney transplantation requires the reduction of these anti-A or B titers against these ABO antigens at the time of implantation and probably during the first critical 2 weeks post-transplantation. This phenomenon, without graft rejection, despite re-emergence of the specific antibodies, has been named accommodation. The mechanisms involved and its very existence, however, remains speculative. So what is currently the therapeutic strategy? Recipients of ABO-incompatible kidney transplants receive standard clinical immune suppression with therapeutic exposure at the time of transplantation. Key to the procedure is adequate pre-transplant removal by plasmapheresis or immune absorption of the circulating specific ABO antibodies. ABO-specific immunoabsorption columns are probably equally effective in removing circulating antibodies as standard plasmapheresis is, but they offer the benefits of less coagulation and/or infectious complications. Finally, to counter ABO antibodies, B-cell depletion and/or only IV immunoglobulins are usually included. So what do we know on the long term about ABO-incompatible kidney transplantation? The results are actually quite good using current strategies, and key outcome parameters are comparable to those obtained with ABO-compatible kidney transplants. ABO-incompatible transplantation is also not a very novel procedure. Large experience from Japan has documented long-term success rates that are comparable to ABO-compatible transplants. Coming now back to our patient, the risk-benefit evaluation included the option of a preemptive procedure and anti-ABO8 titers within the acceptable range. A spousal to female donation carries, however, the potential risk for undetected previous sensitization, but without pregnancies, no detectable specific HLA antibodies, this risk in this patient was considered to be low. She received a timely, successful ABO-incompatible kidney transplant without immunological complications. So what have we learned? What are the take-home messages? First, ABO-incompatible kidney transplant is a successful procedure. The challenge is to prevent acute antibody-mediated rejection. The strategy is adequate immune suppression and removal of ABO antibodies. Finally, an individualized risk-benefit strategy is of paramount importance for the patient.